Welcome to JACC This Week, where impactful science meets global insights. I'm Dr. Carolyn M, here with Dr. Harlan Krumholz as we go beyond just summarizing the papers and discuss why findings matter, what was debated, and how the field should be thinking differently. A whole issue on amyloidosis. What is up with that, Harlan? Tell us about it.
Look, this is one of the hottest areas in cardiology right now, and it's exciting. I mean, here's a disease that really we had very few options for before.
Yeah.
And now there's an abundance of things happening. The science is breathtaking. The progress is also extraordinarily rapid.
Mm-hmm.
And it's something people need to learn about. People may not recognize just how common this is. And I think at a time when we didn't have any tools to treat it, we were kind of hand waving at it. It didn't really almost matter if people got labeled appropriately, but now it does. It really does. It's no longer a niche diagnosis. It's common, it's progressive, and increasingly it is treatable. And what that means is that our biggest challenges are shifting. The questions are no longer just whether we can diagnose ATTR cardiomyopathy, but how we diagnose it, how we stage it, how we choose therapy, how we follow patients once treatment begins. How do we make sure that people actually get access to these? They can afford it. There's not financial duress as a result of it. So, we at the journal are seeing now a large number of really good papers that are coming in. And we believe that it's an area that readers would benefit from learning about, and that the field, is in an exciting moment. Just, there are a few other areas like this, but this is one of them. And again, as we talked about last time, we didn't make a call for articles. We just are curating the things that we have in the pipeline. And when we've got a nice collection of articles on a particular topic, like we did on this topic, and again, when I can pull in a few extra papers from the other JACC journals that are also on the topic that have been published that people might not have seen, then next thing you know, we've got a spectacular issue on it. And it's a nice curated, focused issue. People want to read it. They're kind of learning about this from different angles. It's a really nice way to be engaged with the literature.
I agree. And you know what? I'm going to ask you what stood out in the issue. But for me, I think one thing that I learned from the Veterans Health Administration paper was just astounding, that the median delay in diagnosing cardiac amyloidosis was 490 days, almost 500 days of delay.
So this was a really great study by Sandhu and colleagues that looked at about 2,500 veterans with ATTR cardiomyopathy. And just as you say, the median time diagnosis, about 16 months. And if you look at the time from the first loop diuretic prescription, so they are being treated for heart failure. And then, to when they actually recognize and get the appropriate labeling can take even 2 years. Yeah. And a quarter of the patients waited more than 3 years for a diagnosis. And what was particularly striking in this paper was who experienced the longest delays. Patients with AFib, coronary artery disease, or chronic kidney disease had significantly longer times to diagnosis. And I think it's because people are sort of attributing the heart failure to other causes. But these are exactly the patients in whom conditions need to be thinking differently about the possibility that amyloid's playing a role, not to anchor on alternative explanations for heart failure and then sort of have what we sometimes call premature closure on that reason, and to keep an open mind about this. And again, especially since there are treatments.
Exactly. And you know what? It goes very nicely with that other paper, I think from the Brigham group, that talks about the timing of mortality benefit, right? And I mean, there we see that the mortality curves in the ATTR cardiomyopathy trials begin to diverge already at 12 to 18 months. So we have a paper right next to that other paper showing that mortality benefits occur early. And we have also papers that are secondary analysis from the main clinical trials, again, showing very, very good and encouraging data of the benefit that patients can reap from these therapies. I think it all really culminates in, I love your editor's page, by the way, once again.
Thank you.
Here's the fan mail part, but especially what you wrote as computable diagnosis as a moral imperative. Do you want to tell us a little bit more? Yeah.
Well, so first of all, I want to just reinforce what you're saying, which is that yeah, the issue has got a wide variety of content on amyloid, but there are some
Yeah.
key themes, and I do think at least one of them is you got that VA paper talking about delays in diagnosis, and you've got this other paper that's reinforcing this critical point that morbidity accumulates early, and waiting months to start therapy is not just neutral. That your waiting time is actually putting people at risk in that period of where they're not being treated appropriately, and has a cost. I mean, a health cost to patients. And it sort of reframed the urgency. It says delays in diagnosis treatment translate directly into preventable hospitalizations and death, not years down the line, but even within months.
Yeah.
And that we've got a lot more to learn about this, but I thought that was really putting it in position when I was thinking what to write on the editor's page. I came up with this title, Computable Diagnosis is a Moral Imperative, because increasingly with our digital data, we have the capacity to analyze that data, whether it's electrocardiograms or echocardiograms or just the histories, to be able to identify people who have a higher likelihood. It's sort of, we can do mass screening with existing data within the repositories of data that exist within our electronic health records. And this can then trigger the next step, which might be another echocardiogram, it might be some just reexamination of the history, putting it together, the carpal tunnel, the spinal stenosis, what's going on with the patient, and trying to say that,
Yeah.
wow, this could be someone who might have amyloid. We should not be missing that possibility. And saying that if we delay in implementing the kind of systems that can more fully provide this diagnostic support so that we can identify people as early as possible, that's just not lagging. That's actually unethical. It's a moral thing, because we can, but we don't.
Yeah.
And so I was trying to put this in sort of a perspective of saying that, we can systematically identify people who would benefit from these disease modifying therapies, and we can't choose not to do it because it's operationally inconvenient.
Yes.
Because then we're accepting preventable suffering. And so it's up to us to align incentives, create the infrastructure investment, create the capacity. And then I said there should be equity by design so that people aren't excluded because of, their ability to pay.
Yeah.
And I think this is important because I had heard people say, you can identify people, but our echo lab can't handle the volume if all of a sudden you start identifying a bunch of people. And, to me, it's like, that's not the right way to be thinking. You need to think, now, how do we redesign our labs? And as you know very well, with the way that we're creating AI systems that can provide more efficient ways of interpreting the echocardiographic data, for example, or the electrocardiographic data, for example, that we should be able to create highly efficient systems, do the screening, get to the right diagnosis for each patient.
I am so appreciating what you said about equity, because it also therefore means it allows us to take a global view. I am thinking of the many, many diverse countries, even where I'm from, Asia Pacific, where applying AI at the bedside is a far dream at the moment. But I really, really share your view, Harlan, that AI is also here to bridge those disparities. And it's not just AI, it's just awareness that we should be looking out for these treatable conditions. And by the way, if there are any listeners out there who are going, oh my, the cardiac amyloidosis field is just moving so quickly. There are all kinds of different therapies coming out. I don't even know how to layer them. All kinds of different diagnostics. Well, guess what? In the middle of this issue is a beautiful ACC concise clinical guidance on all you need to know about amyloidosis evaluation and management as we know it now. I think it's a amazingly well done paper, very, very practical, and everyone should get their hands on it because it will bring you up to speed immediately.
I agree. It's a one-stop shop for really bringing this together. I love the idea of this concise clinical guidance because it's just what a lot of people need, which is, hey, bring me up to speed quickly so I really understand what's going on. And we're pleased to publish it in the journal, but it's really a kudos to the ACC for pulling these together.
Yeah. So get your hands on the issue. Now, I'm going to switch topics a little bit, Harlan, because in this week's issue as well are a few papers that are secondary analysis from clinical trials. And the question I always get is, what's a bar for these secondary papers, right? I'm kind of getting a lot of the audience sometimes saying, another subgroup analysis from a trial. Like, where is the boundary here? What are your thoughts?
Well, that's a really good question. Actually, there's another editor's page I wrote that's about this topic in a different issue where we were featuring a fair number of secondary analyses. But, in this particular case, you're right, and look, at JACC, we want to be able to compete for the very best trials. We're very interested in competing for the top trials at the time that they're released as well with everyone else. I think we're going to get there. But we're also interested in secondary analyses, not as, second-rate studies, but top-rate studies that are asking really good questions that weren't really handled well in the trial, in the sense that, there needed to be greater depth. The question needed to be framed in different ways. Now, everyone should be asking when they see secondary trials is like, is it a good question? Are they well positioned to answer it? How strong is the evidence? To what degree does it represent an exploratory analysis versus something that was pre-specified and is still testing another hypothesis, albeit not with the same strength as the primary endpoint, but is sort of positioned for inference in that way. And, I think at JACC, it's got to be a pretty strong study. It's got to be a good question. It's got to be something lots of people are wondering about. It's got to be something that's adding color and depth to the insights from the primary publication for us to be interested in it. And that's not to say there aren't plenty of other good ones that we'll pass on. They're good. But, we have a pretty tough bar. We're accepting less than 5% of the papers, and, we have pretty high standards. So if you see a secondary analysis, I hope you'll be impressed that it's asking a good question and it's positioning you to have greater insight into something that you didn't have before, rather than just a pedestrian, sort of paper mill kind of approach where, like, we've got just putting out a bunch of papers. And the very best trialists, they're too busy to put out nonsense. So, the very best trialists are putting out good secondary analyses that are complementing the trials in positive ways. But there are other cases where people are just trying to get publications, and that's fine. But that's not going to end up in JACC.
Thank you. That was really, really helpful. You know what? To round us up, though, Harlan, could I just ask you for one-line takeaways from this week's issue? Something that maybe surprised you, something you hope listeners will apply, or perhaps something you're still pondering.
Yeah, I mean, well, I don't know if I can do it in one line, but I do think that this is it's a feast of papers that provide us both with some imperatives for today, which is we got to do better at diagnosis. We got to move faster. We've got to figure out ways to systematically identify the people who can benefit. Time matters in the treatment of amyloid heart disease, so we've got to keep that in mind. And then, the issue also has some future perspectives, like the use of CMR, extracellular volume.
Yes, love that paper.
As a marker that people might want to do, additional biomarkers that build on biomarkers like, NT-proBNP and troponin that we might be using in the future. And then we have a couple papers actually on biomarkers that people might enjoy and find interesting. So, overall, I don't think this is going to be the last people are going to see of JACC publishing stuff in this area, but we all got to catch up because it's a common progressive disease, and now we've got new tools, we can help people, and there's a lot to learn.
Beautifully said. Thank you so much, Harlan. Well, readers, you heard it right here. I should say listeners. And you know what? I cannot wait already for you to tune in next week, because next week's issue is super, super close to my heart. Okay, I'm not gonna give it away right now. So remember, tune in next week. Thanks, Harlan.
It's a great issue, yeah. All right, thanks, Carolyn.
You've been listening to JACC This Week, bringing impactful science with global insights. If you liked what you heard, subscribe, share, and email us at jacc@acc.org. See you again next week.